We're going to hear from another one of our experts, and she is also, we're very pleased to say, also a member of our board of directors. This is Dr. Anupama Kale, and she's going to be talking to us about gait and balance today.
So it looks like I'm a little shorter than everybody else, so I will. So if I have not positioned this correctly, you let me know. Well, it is a pleasure to be here today. It's nice to see a lot of friendly faces in the audience. And I'm just going to touch, gait and balance is a pretty complex topic. So I'm just going to touch upon, some issues that you might come across just moving forward. Okay. So whenever I do a talk, I just like to start with definitions, just because sometimes these can seem like very easy concepts, but we don't realize how much goes into it. So as far as gait's concerned, just to be a very, very simple definition, it's just a person's manner of walking. When we put postural control into that, we realize that you actually have to integrate information from a couple different systems of the body, mainly our vision, our sense in space, and even our vestibular system. And then we have to take all of that information, integrate it, and adapt it to a continuous changing environment. And so when we think about balance, it's actually the control of the body's center of mass over its base of support to actually achieve postural equilibrium and orientation. So why do we want to talk about gait and balance issues today? Well, one thing is that, first of all, it can occur at any time. It doesn't necessarily occur in everyone, but it will to some degree at some point in all of your disease. Having said that, it occurs in different degrees, and more significant issues are, usually tend to occur later stages, but falls are not exclusive to those people that are older or have advanced Parkinson's disease. And in fact, they've been able to show that the risk of fall-related injuries is higher than controls up to 10 years before patients actually develop Parkinson's, or let's say motor onset of Parkinson's. And so fall rates are actually quite high in PD. And so you can see the schematic shows 62%. A recent systematic study showed that 35 to 90% of patients with Parkinson's disease have fallen at least once. The average rate, again, is in the 60s. And recurrent falls account for about 39 to 40% of those falls. So again, this is just a quick overview today, but these are some of the topics that we're going to touch upon. So what are the gait and balance changes that you can see in Parkinson's disease? Do gait and balance issues respond to levodopa? That's the most common medicine or Sinemet that we use, or we use some form of dopamine. Is there a link between cognition, or thinking and memory, and gait and balance? What are some ways we can target gait and balance issues? And then I'm also just going to touch upon freezing of gait, because I know a lot of you experience that from time to time. So we saw a form of this picture in Dr. Elmer's talk before, and this is a very familiar picture to a lot of people. And this is something that represents the typical Parkinsonian gait. So as you know, when you develop Parkinson's disease, you tend to become slower. You have what we call a hypokinetic gait. Your posture becomes forward, becomes stooped. You then have short, shuffling steps. Again, your arm swing tends to decrease, and it's usually more on one side than the other. And then people then take multiple steps on turns, something we call en bloc turning. It's almost like you're turning like a statue. So other balance changes that we see, or walking changes that we see, are festination. So it's almost like people speed up, and then all of a sudden they're running. People have difficulty initiating or continuing their movement, something called freezing of gait. And then one of the cardinal features of Parkinson's, when we think about the four cardinal features being tremor, rigidity, bradykinesia, the fourth feature is loss of postural stability. So these are our protective reflexes to actually stay upright. And so when we start to develop these issues, it can ultimately be debilitating, because what it can make difficult to do are those daily activities that we need to do, like showering, getting dressed, and it makes it difficult to do those things safely. And so ultimately, if we start to have issues with that, it can start to affect our independence, our quality of life, because it can lead to falls or injuries. And so a lot of papers, I don't know if you can see this very well, but a lot of papers, and this paper in particular has described it as kind of a vicious cycle. You develop these issues of postural stability, gait impairment, That leads to frequent falls, and in turn, you start to have this whole snowball effect, which ultimately, and not ultimately, but which can ultimately lead to being immobilized or then also higher risk of nursing home admissions. So when we think about gait and balance, the main thing is it can be quite challenging to treat. And the main reason is because we talked about how there are a lot of systems that go into us walking. So right now, as far as what we try to do to actually manage that is, first of all, we start to think about, can we adjust the medicines that you're on? And that's going to be medicines that help the bradykinesia and rigidity. So when we do that, we'll talk about that in the next one, but that can improve your gait speed, your stride length, etc. We also think about exercise and physical occupational therapies. The main thing, though, is it doesn't necessarily respond well to all the medical and surgical therapies that we have currently. So as I was talking about before, one of our first steps is to adjust your PD medications. So we do this to see if we can adjust the medications to see if the symptoms that you're experiencing, like slowness and stiffness, are not necessarily contributing or worsening your gait. And so when we do this, we can sometimes see improvements in gait speed, stride length, arm swing. But it's important to remember that when we have complications like dyskinesias, the extra wiggly movements that Dr. Elmer was talking about before, sometimes that can actually cause instability. And so we might actually have to back off on the medications or use some of the newer medications that have been released to treat dyskinesias. So do balance and gait problems respond to dopamine, or do all of them? So the simple answer is no. So as I mentioned before, the symptoms that are responsive are the slowness and the stiffness, but the non-dopa responsive symptoms are the postural instability. One can develop some types of freezing of gait, which I'll touch upon later, and then the festinating gait that we see. The more complex answer, though, is that we're starting to realize that there are a lot of other chemicals involved in gait and balance. So usually when you go to your Parkinson's disease doctor, or even when you start to read about Parkinson's disease, there's a lot of emphasis on dopamine. So we learn about how the dopaminergic neurons are starting to degenerate, how we treat Parkinson's with dopamine medicines, but we're starting to realize that another neurochemical, acetylcholine, actually can play a role. And the cholinergic systems actually have quite a widespread influence on our whole body. It's a chemical used by the motor neurons to activate muscles, and it also plays a role in how we process information. So when we think about that, then we start to think about, is there a connection between gait and balance and cognitive impairment? And yes, there is. So when we think about people who are starting to develop thinking and memory problems, it can actually affect your ability to regain your balance or normalize your gait when you're walking. Freezing of gait, we've seen, has been associated with problems of executive functioning. And we've actually also seen that there's a greater relationship between cognitive abilities as well as walking functions in some of the subtypes of PD. So a lot of times you'll hear about tremor predominant versus akinetic rigid, or tremor predominant versus PIGD, which is the postural gait and instability type that was kind of described in the 1990s by a gentleman named Jankovic. So when we start to think about management strategies, the one thing that I want to emphasize today is exercise. And we all know that exercise actually helps delay the progression of Parkinson's disease, but it's actually one of the best tools that we have to help our balance and gait. It's important for all patients with Parkinson's disease, but especially those patients who have walking and balance problems. And then you come across the question, is there an exercise that I should do? A lot of patients often come with that question, and honestly, there's no perfect exercise. The main thing is to make sure that you're doing something active and that something is something you like to do, because if you don't like rock steady boxing, for example, it's a fantastic exercise, but if you don't like it, and I actually had one patient say, I dreaded going to it, then don't do it, because it's not going to help you. But having said that, we're going to talk about rock steady boxing or non-contact boxing in a second. But these are some of the exercises that have been shown to be especially helpful in gait and balance. And so we always talk about yoga, and if we think about how does yoga help us, it actually emphasizes our postural alignment, as well as movements within postures. It gives us a progression from body awareness to relaxation to flexibility to strength activities, and it actually has been shown to improve posture, strength, balance gait, and flexibility. Same thing with Tai Chi. This is where you focus on dynamic postural control through exercises by shifting your weight, okay? It involves cognitive engagement, and it's actually been shown to improve gait, your joint excursion, and it's been shown to reduce falls. Again, non-contact boxing is a great, great exercise. Think about it. You're working your core, you're moving around, you're taking those steps. It's working on dynamic balance. There are multi-directional movements that are involved, large amplitude movements that some of you have learned in the PT exercises like PT, LSVT big. There have been patients who have shown that it actually improves their quality of life. That's what they report. And it improves your balance and gait. And then dance. We did some dance earlier, and even I felt good. I mean, it's a social activity. It gets you engaged with the people that are around you. It's fun. And then you have to start to think about auditory cueing. You know, there's something to be said about stepping to the beat, which we'll talk about in freezing of gait. But it's a social activity, and it's fun. So it improves balance, walking, and dual tasking while you do it, too. Think about those tango classes that your wife wants to take you to. So the next step, too, is then PT and OT. And so there's this concept of prehabilitation that a lot of people, say, for example, the University of Florida have talked to. So the problem is that with Parkinson's disease, say you're doing very well, you know, you're walking fine, you're not having any falls, you're like, I don't need to do anything. But the problem is we wait far too long to start to develop some of these techniques. And so again, that's where the concept of prehabilitation comes in. I want you to start thinking about these techniques and actually start practicing some of these techniques before you get to the point where you're falling. Because then, you know, then it starts to snowball. So PT and OT are very, very important in your care. They can help prevent falls. They teach you ways to fall to minimize injury if you do fall. They can teach you specific exercises to improve your strength, mobility, and balance. And they can also address certain features or symptoms by specific interventions. So for example, you know, you have a hard time getting up out of the chair. Then you want to strengthen your hamstring. So they can start to focus on those issues and tailor the treatment to your particular issues. And then they can also evaluate you for whether ambulatory assistance is helpful, so a cane or a walker. And then you also want to make sure that you evaluate your home safety. So your home is your castle, right? You want to make sure you're not falling in your home. So make sure you remove any loose rugs, any loose cords, so you prevent tripping. A lot of times people have that uneven floor that they say, oh, I'm going to fix that later. Fix it now. You want to make sure you add extra night lights or lighting in certain areas. So say, for example, if you tend to freeze in the kitchen, things like that. You want to widen doorways, add ramps to accommodate any kind of assistive devices you might have, so the walkers that you're using, the wheelchairs. And then you also want to install adaptive equipment. So when you get into the shower, you want a bar that you can grab on. You want raised toilet seats so it's much more easy to get up. Lift chairs are also very helpful. So again, I mentioned before that we would just touch upon freezing of gait. And this is a phenomenon that's experienced by a lot of people, some people that I can even see here. And basically, it's just a very brief, kind of intermittent phenomenon that occurs. It's when you are starting to walk, usually that's when it starts, and all of a sudden you feel frozen. So a lot of times people feel like they are stuck or they are glued to the floor. People use the term there are magnets in the floor. And so it can make it difficult to get walking. So to put it simply, you know, when we're growing and we're maturing, we start to develop circuits and feedback loops that automatically facilitate our balance and walking, okay? What happens in Parkinson's disease that we've seen is that the function of this is altered. And so those circuits that facilitate automatic synchronous movements are now impaired. So one way to think about it, an analogy to think about it, is the automatic transmission that you have in your car. You know, a lot of you probably have automatic cars. You jump into the car, you put it into gear, and then you're off. You know, you've got smooth drive, smooth turn. Then compare it to, say, for example, a manual transmission. Unless you're very good, it takes a lot of focus, you're shifting gears, and things can be a little more jerky and maybe non-continuous or incontinuous. So there are a lot of triggers that have been shown as far as freezing of gait is concerned. Again, the earliest symptom is that people start to realize that when they get up from a chair, all of a sudden they can't get going. something called gait initiation failure. Other places that are particularly difficult for people are narrow passages. So think about your hallway, your closet entry. People have difficulty turning around. And then especially when they're dual tasking. So maybe you think about your, younger relatives, maybe your teenage grandkids, they're always on their phone walking around. Well, a lot of us actually do similar things. So say, for example, you're walking around the grocery store, you've got the grocery list in your head, and you're dual tasking, and so that can be a trigger. Other environmental triggers include close spaces or crowded spaces, so elevators, busy crowds, or if there's an obstacle in your way. There are emotional triggers as well. You're rushing to that meeting, you're rushing to that dinner, you're all of a sudden startled by someone. Stress, anxiety, and fear and despair can actually play a role. And so the main thing is that, so we talked about how, or we didn't talk too much about it, but as far as addressing freezing of gait, sometimes medications can help, and sometimes they don't necessarily help. And what I mean to say by that is that if, for example, you take your medicine and you realize that you're freezing less, so that might be a dopa-responsive symptom. But some people realize that when they take their medicine, it's not helping, or in some people, a little rarer, it actually worsens their symptom. So take the medication out of the, picture. You start to realize you have to have strategies, regardless of how to deal with these situations. And so the first thing to do when you start to freeze is to immediately realize that you're actually freezing, okay? Because a lot of times people want to just go. You get very anxious, you get frustrated, and that's actually going to increase your risk of falls. And so what happens is a lot of people continue to move their body forward while their feet are still planted, and that's going to precipitate a fall. And then there are some certain tricks that you can do to trick yourself and to start walking again. So a lot of times counting to 3 and actually marching in place can be helpful. You can count out loud or in your head, but something rhythmically, or you can even step to a tune, something that you like, even Happy Birthday or something like that. Sometimes just tricking yourself by moving into a different direction, moving sideways all of a sudden, or taking a step back can trick yourself into walking. And a lot of people find that visual cues are very helpful. So sometimes you can step over a small object, or especially lines that you see in the floor. And so say, for example, if you have a difficult time in a particular area of your home, for example, that closet or the kitchen, you can actually place visual cues for yourself. So maybe you can place pieces of tape on the ground to help step over that line. So just as kind of a overall wrap-up, we have to remember that when we treat gait dysfunction in PD, we have to take a multidisciplinary approach. You're going to talk to your doctors about medications, and you're going to note the relationship you have to your medication to maximize treatment of dopa-responsive symptoms. So keeping diaries are very helpful. So for example, when you take a medicine, what symptoms are being helped as you're wearing off from the medication? What symptoms are you now experiencing? You want to educate yourself about the types of gait difficulties, because as we see, balance and gait is a very broad topic. You could be actually festinating and not freezing, and you need to be able to communicate this to your doctor so that he can help you a little bit better. You also want to make sure that you are safe at all times. Recognize situations that have a high fall risk. And then just theories, as we talked about or touched upon, is that walking is no longer an automatic thing. It becomes difficult to focus on each step, speed and posture, to attend and adjust to your surroundings. The main thing is that you practice creating new motor programs to make gait more automatic again, and then there is research underway to understand the pathways that are involved. So other take-home points. The one thing that I want to really impress upon you today is that a lot of times when people have Parkinson's or they receive that diagnosis, they suddenly feel hopeless. But this is something that you can do and you have control over that can actually positively impact your disease. So I want you to be an active participant in your treatment, okay? And that's about it.